This is the second part of the inflammation lectures. We're going to go through chronic inflammation and then take a look at some of the systemic responses, fever in particular, fever patterns, and some of the other manifestations within the body from inflammation. So, chronic inflammation, a little less complicated in terms of all the different interactions than what you see in acute inflammation. It is self-perpetuating, meaning it can continue on. It makes itself continue, lasting weeks, months, or even years. It can develop from acute inflammation that fails to resolve itself, or from an injury that fails to actually initiate an acute response. So you don't have to have acute to get to chronic. You can have an injury that we never really get to the point where the acute inflammatory responses take place, and it just goes directly into a chronic situation. There is no exudate involved. Instead, there is an accumulation of fibroblasts. Fibroblasts will lead to scarring. It involves macrophages, or monocytes, and lymphocytes. Now, there are still some small amount of granulites that are involved, particularly if you're going from acute to chronic. You will see neutrophils still playing a small role. There will be a few here and there, but this is primarily an agranular response. So, these are some of the things that can cause can cause chronic inflammation. The things that tend to be the more difficult to deal with are some of these inanimate objects that get there and we don't recognize, and they're in such tiny proportions that we don't realize that they're actually there. I mentioned the differences between the two: very little granulocyte activity, no exudate, and scarring is really a problem. There can be scarring. Remember, in terms of the resolution, there can be scarring in acute inflammation, but scarring is very common in chronic inflammation. So granulomatous inflammation is a very specific type of chronic. It forms what we call a granuloma, which is a small massing of macrophages surrounded by lymphocytes. It's caused most commonly by inanimate things such as the splinters, asbestos, silica, or it's common in fungal infections and things like the mycobacterium, particularly with TB, is a mycobacteria. So that's where you'll see it. It forms what are called the foreign body giant cells. And I thought I had a picture. I guess I left the picture off my PowerPoint. I apologize for that. But these foreign body giant cells, they actually can be visible to the naked eye. They can get large enough that you can actually see them, especially if the inflammation is external. In a surgical setting, you could actually open them and see them. Now, I'm not talking, when I say you can see them, we're still not talking about inches in diameter, but rather, half a centimeter or so. They get large compared to what would be a normal cell you can't see with the naked eye. But these cells are that cluster of whatever that foreign substance is, with that macrophage surrounding it and lymphocytes surrounding it, trying to act on it, but it's like it's been contained and walled off. But there would be not just one of these, but multiple giant body cells that are there impeding function and not really ever resolving themselves or healing. So granulomatous inflammation is a specific form of chronic inflammation. Not all chronic inflammation has these foreign body giant cells. Now, in terms of the systemic manifestations for all of inflammation, I've got a couple of things I need to go through here. First of all, we have what we refer to as the acute phase response. This is linking a little more to that acute inflammation. So you have an increase in plasma proteins being produced. This is your body system. So when I say systemic manifestation, remember, we're not talking just at the area of injury, but the whole body. The body, the immune system, the bone marrow, they respond to what's going on here, and we get ready to deal with this injury. So you will increase the production of your plasma proteins. You'll increase both red blood cells sedimentation rate. This is the rate at which red blood cells settle out of anticoagulated blood. High levels of these proteins indicate an increase in clotting. So this is what's necessary to block off an area so it doesn't spread. So increased erythrocyte sedimentation rate is the rate at which red blood cells settle out of anticoagulated blood. High levels indicate high levels of proteins, which leads to an increase in clotting. So we look at this as a measure. We can test for this as a measure of the ability of the blood to clot. And when that level goes up, it tells us there's an injury somewhere. And then there's increased skeletal muscle breakdown. That means that we break down the skeletal muscle. We need the resources that are in skeletal muscles. They'll break them down in order to respond to this injury. So again, you've got to think the level of the injury. If again a small cut in my hand is not necessarily going to lead to an acute phase response that's very profound, but damage internally will certainly an acute infection, a bacterial infection, would lead to this kind of response. The white blood cell response, particularly coming from the bone marrow, leukocytosis, we are going to start making enormous numbers of white blood cells. So that's an initial response. Really at the end of the inflammatory response, because we work so hard to make them and then they break down, you can actually see a real drop in white blood cell count at the very end of an inflammatory response, kind of initiating that the body said, okay, I've done it, now I'm taking a little break before we go back to the normal function. And then fevers, often referred to as pyrexia, leads to an increase in metabolism, which then increases the need for red blood cells. So fever is linked to the body saying, okay, if I heat up, then I'm going to make greater demands and I'm going to help get everything going. So fever is a good thing. We do a lot to control fever, but there's some real benefit to fever as to what it initiates in the body, one of which increases the demand for red blood cells. So the bone marrow gets triggered to make more red blood cells to help provide more oxygen to deal with the situation in the body. Causes of fever, I list what the core body temperature is, and just as a reminder that it's controlled in the hypothalamus. I do hope you know that already from your A&P 1. The causes of fever, the term pyrogens refers to something that's fever causing. Pyrogens can be microorganisms, bacteria and viruses, the toxins they produce. You have some chemical mediators that will cause fever. And then there are other things that are non-infectious. A myocardial infarction, a heart attack can lead to an increased body temperature. Any kind of trauma, surgery, cancer cells are not infectious, and they can lead to fever responses. If you have a pulmonary embolism, that will cause a increase in body temperature. So you have things like microorganisms or the toxins produced from them that will cause fever. But not all fever is related to infection. Some are related to injury, internal injuries such as a heart attack, cancer cells, and so forth. There are 4 stages to fever. First, the prodromal stage is that feeling of, that's where that malaise, or you feel miserable, you ache, pains, and fatigue. It's usually followed by chills, which include vasoconstriction, and then the goosebumps, the piloerection, which precedes the shaking. So chill usually comes with first a feeling of cold and then a shaking kind of a feel. Flush is now vasodilation that occurs, particularly at the skin level. So that's when the person starts to actually feel warm to the touch. And then defervescence or sweating is the final stage, and is a really not always occurring, depending upon if there's an intervention. If you give a Tylenol or take something for the fever, you may not get to a full sweat, depends upon how high the temperature rises. Fever definitely runs through the first 3, and if left unchecked, untreated, often will run through all 4 phases. Not always, but often. And then there are patterns for fever. These patterns are explained in your book, so please be certain that you go through and read through the patterns. Intermittent fever is where the temperature returns to normal at least once every 24 hours. Remittent fever is the temperature does not return to normal, but it does vary a few degrees in either direction. So it's Russian high and low, but it doesn't ever come back to normal. Sustained fever patterns are where the temperature remains above normal with little variation. And then recurrent fever patterns are episodes of fever which last several days. So you have a rise in temperature. It can be sustained or it can be more remittent. It can go either way, but you have a rise in temperature, and then it's followed by a day or two or maybe even 3 of normal temperature, and then you go through another phase and you have another set of fever, whether sustained or remittent. So it's that intermittent is within a day. Every day it comes back to normal and then goes back up again. That's intermittent. But recurrent is you'll have several days or a week of fever, maybe even longer. Then you'll have several days without any fever. You think you're better, and then it comes back again. That's particularly common in things like malaria, Lyme disease, and TB have a lot of recurrent fever. Neurogenic fever is fever that's caused by damage to the hypothalamus. So that's where that actually is occurring. So that's a brain injury issue. In general, we can say 1 degree of Celsius increase is equal to a 15 beat per minute increase in heart rate. So if you're not comfortable yet doing temperatures in Celsius, look at Fahrenheit. So with each degree in body temperature, the heart rate goes up 10 beats per minute. This is an important factor in starting to look at, well, how does the cardiovascular system get related to changes in fever or body temperature? And again, that's also linking back to inflammation. So if you have inflammation, fever, how's it going to affect the cardiovascular function? And then the common manifestations, hopefully most of this terminology is things you're familiar with. Anorexia, I believe we've mentioned that in earlier lectures. Anorexia refers to lack of appetite. It's not anorexia nervosa, where it's lack of desire for food from a psychological disorder. This is lack of appetite, lack of desire for food due to some physiological problem. Malaise is muscle pain, arthralgias, joint pain, fatigue, increased respiratory rate, increased heart rate. We've already mentioned the heart rate goes up, so then respiratory rate follows. Dehydration, headache, and especially in children, you can see seizures and possible delirium. All of those are manifestations. So be sure you read through this information in the chapter as well, because it will take you through a little more detail on this. If I kind of went fast with that. If you don't want to listen to me again, definitely go to the book. It has all of this exact same material going on in it.